When we get into tumor classification, we also have to look at the extent of the disease. Stage 0 means that the growth is in situ. There's no invasion. That means the cell has completely stayed in its little area. It's not gone outside of its capsule. It's not wandered from the tissue of origin. It's still where it belongs for the most part, and it's in situ. It's in place, or in the situation. It's where it belongs. Stage 1, we're localized, but we've still stayed in the tissue of origin. So if we're a prostate cancer, we've stayed in the prostate. We haven't wandered to lung. We haven't wandered to bone. Stage 2, we're looking at limited local spread. So we're starting to get nearby structures. So if I've got lung cancer, it may have started spreading to bone, especially those that are close by. Stage 3, we've got extensive local and regional spread. We're starting to get outside of that area by a pretty good distance now. And finally, stage 4 is metastasis, and this is where we're pretty much anywhere that these cells have gone from head to foot. Their control and their growth is no longer set by any boundary of any of the physiological structures of the body. Just like on our differentiation, the lower the number, the better the chances of survival. Just so you have some idea of some of the terminology, sarcoma typically is defined as connective tissue. So we're looking at things like blood vessels, lymph nodes, bone marrow, bone or muscles. When you hear a patient with a type of sarcoma, you know it's in a connective tissue. Likewise, carcinoma, typically these are in the epithelial cells, and there's a couple more differentiations beyond that. The one you'll probably be most familiar with is squamous cells, and these are usually found on skin, and so you'll hear somebody say they've got a squamous growth wherever on the face, whatever, from sun exposure. So carcinomas typically affect those epithelial cells. Now remember, most of our epithelial cells are wherever there's contact with the outside environment, so or places where a lot of absorption needs to take place. Along our GI tract, for example, there are sufficient numbers of epithelial cells there to allow that transport of nutrients from the digested food into the circulation. We also see epithelial cells anywhere we get a lot of wear. Typically our skin is one of those areas because we're constantly in contact with our environment, so that's an epithelial type cell. The inside of our mucous membranes is typically epithelial cells as well. So a repeat of that previous slide. I keep meaning to take it out. Let's just have a brief conversation here about lung cancer. In class, we actually stopped and talked amongst ourselves a little bit. Lung cancer is on the rise, particularly in women. Past versions of your book mentioned breast cancer was the number one killer of women, as lung cancer was the number one killer of men. But at this point now, lung cancer is the most common cause of death of cancers of both male and females. And one of the reasons that this is the case is women are beginning to smoke more. They are actually a growing population of smokers. When we look at lung cancer, we need to be watching for certain things. Remember back to that caution acronym, and you're going to be most interested in the N at this point. And that's that nagging cough or hoarseness that comes with that. And we want to watch for hemoptysis, that coughing up of blood or blood-stained sputum and it's coming from anywhere between the bronchi. It can be coming from the larynx, can be coming from the trachea, or it can actually be coming from the lungs. If a patient's got a bloody cough, we need to investigate what's causing that. These patients are more than likely going to need some type of a scope to go down and look and examine the structures. Sputum cultures are rarely used to diagnose lung cancer. We're actually going to need to go in there and identify the structure and look at it and do sweepings, brushings, and washings of those materials in order to make that diagnosis. Some goals of cancer care. We can try to cure. I mean, ultimately, that's the best thing that we can do. So a curative example could be something like removal of a prostate. That may very well cure our patient. Control. If we can't really get rid of the cancerous growth, can we at least control its growth to make sure that the signs and symptoms don't get any worse? And finally, palliative care, and we may do things like reducing the size of a growth in order to reduce pressure on organs. Some common treatment methods: surgery to remove the tumor and the surrounding cells, radiation, and that's we're localizing X-rays to a tumor because radiation kills cells, so we can actually guide that to the area we need to target, and we're actually pretty good at that. That's gotten significantly better over the years. Chemotherapy is a systemic treatment that destroys cancer cells, and then we also have biologicals that we'll look at later. Some of the surgical things that we need to look at, some of the reasons we have surgery, preventative. And if you'll recall back to that GI content, we talked about the removal of polyps. We're just preventing the formation of colon cancer by removing those polyps, and then we look at them and see how questionable they are as far as their makeup. Do they still look like a colon cell? Have they started to change? That kind of stuff, and we'll do that. And remember, about 10% of those will actually be cancerous or precancerous. We can have a surgery, have a biopsy, and that's where we actually remove some of the material to look at a couple of different types of biopsies that you need to be aware of. We can have incisional, and that's typically used with skin growths. We try to remove the entire area and also a margin around it with a little safety net, if you will. This helps prevent seeding and aids in the staging as the entire tumor is taken to the pathologist, so there's no question about whether we got a good representative sample of the growth. We took the entire growth for exam. We can have an incisional biopsies. These are typically done when the mass is large, and they go in and remove a wedge-shaped area of material. The problem with incisional biopsies, where you can get into issues, if you don't get a good representative sample of that material, you can actually get a false negative because we may not have actually obtained any cancerous cells in that area. It may just simply be